Hello there, my name is Margaret Kernan and you are listening to the Early Childhood Workforce Initiative webinar. The initiative is hosted by International Step-by-Step Association and Results for Development. This year's webinars are coming to you thanks to a partnership with International Child Development Initiatives. Before getting on to the topic of today's webinar, I'd first like to acknowledge the financial supporters of the Early Childhood Workforce Initiative. Bernard Van Leer Foundation, the Elma Foundation, Open Society Foundations, and the Jacobs Foundation. And of course, a special welcome to you, the listeners, who are joining us today from all continents. Our topic today is about scaling up the early childhood workforce to support children birth to age 3. We are going to be talking particularly about the position of the paraprofessionals and community volunteers who are directly involved in home visiting programs, aiming to support the caregivers to ensure better outcomes for their children. These are the issues that we thought it is the most important to address today. Firstly, effective training and mentoring early childhood workers involved in delivering services, the strengths and challenges in professionalizing and retaining the workforces as programs go to scale. And another important issue is enhancing the job satisfaction of the workforce, who may be volunteers or receiving low pay. You, the listeners, also had questions for us, and these are some of the issues that you wanted us to address today. Firstly, what are the essential skills and knowledge when working with children from birth to 3 years? What are paraprofessionals expected to be able to do in their work with families on a day-to-day basis? Many of you were also interested in financial stability. So what strategies can we employ to ensure financial stability for the workforce? And lastly, which lessons learned can be applied in places where there are no donors or where government and community systems are absent and weak? There were other questions too, but hopefully we'll get onto those later. We're going to be focusing on 2 initiatives. Firstly, the CUNA Mass Home Visiting Program in Peru, and secondly, a program in Mozambique designed to integrate early childhood development screening and counseling into the routine work of community health workers. One of the reasons why these countries and programs were selected for today's discussion is that they have been the subject of recent research designed to examine the situation of the workforce in programs targeting very young children and their caregivers. So I'm delighted to introduce you to our panelists, all of whom have been involved in some form or another in these studies. Firstly, Kimberly Josephson, who's a Senior Program Associate in the Results for Development, and Kimberly will be explaining the background to the studies which Results for Development have been undertaking for the Early Childhood Workforce Initiative. Our second panelist is Gabriela Guerrero, a senior researcher at GRADA in Peru. We also will be joined by Jordi Fernandez, who is the country manager of the Mother and Child Health and Nutrition Program of PATH in Mozambique. And finally, Nami Kawaku, who is the consultant based in Seattle, who has been working with Jordi in Mozambique. Before handing over to Kimberly, or if I may call you Kimby today, I will quickly explain how we plan on using the next 75 minutes or so. There will be 2 presentations about each of the programs, starting with Gabriela about Peru, and the second one, a joint one from Jordi and Nami about Mozambique. Each of the presentations will be about 15 minutes, and after each presentation, we will have time for some questions. You will be able to see the presentations on your screen, all going well. If you would like to submit a question during the webinar, you can type this directly in the questions panel on the bottom right-hand side of the screen. We'll try our best to address your questions during the webinar. Finally, good for you to know that the recording of today's webinar and the presentations will be available on the website just in case you need to leave early or you would like to recommend it to a colleague to listen to. Now I'm going to hand over to Kimby, who's going to explain more about the analytical work of the Early Childhood Workforce Initiative. So over to you, Kimby.
Hi, thanks, Margaret. So maybe just for anyone who is new to the Early Childhood Workforce Initiative, I'll just explain a little bit about what we have been doing. So the Early Childhood Workforce Initiative, the vision is that the early childhood workforce is better prepared and supported to provide quality services to family and young children, considering birth to age 8. The initiative takes a global multi-sectoral perspective, and as Margaret mentioned, it's led by a partnership between ISSA and R4D. So far, over the past year to year and a half, we've really been focused on sharing knowledge through webinars like this and a web portal that houses key resources, and research and analysis, which I'll talk about in just a moment. Moving forward, we're also aiming to bring together decision makers at the country level to engage in collaborative learning by sharing their own experiences and working jointly to solve operational challenges related to the ECD and the workforce. So for those who are a little less familiar with R4D, we are a nonprofit based in Washington, D.C., working in the areas of education, health, and nutrition. And one of the ways we work is in providing research and analysis. Over the past year, as a part of ECWI, R4D has been conducting both global and country-level research to better understand the key challenges and opportunities for strengthening the ECD workforce. So I'll start by talking a little bit about some of the global work that we've been doing. There are 4 focus areas that are important for workforce development. The first is competencies and standards, and this is really around the requirements and expectations for what practitioners should know and be able to do. The second is training and professional development, so considering the initial and ongoing training opportunities, both formal and non-formal, as well as links to career advancement. The third is around monitoring and mentoring, so continuous feedback and improvement mechanisms, coaching, supportive supervision. And the last is on recognition of the profession, the pay, the working conditions, job satisfaction, and the status of the early childhood workforce. So through a series of global landscape analyses, we are synthesizing existing evidence around each of these 4 areas. Currently, our team is working on the first 2 around competencies and standards and training and professional development, which will be released in the next couple of months. And these analyses compile, really for the first time, information and literature from across different regions, including low, middle, and high-income countries, from across sectors, education and care, health and nutrition, social and child protection, as well as a number of different roles considering paraprofessionals, professionals, and volunteers, looking particularly at preschool teachers, child care workers, community health workers, and child protection workers, among others. And these landscape analyses identify key findings from across this different literature, as well as areas for further research. And they also include case studies of promising practices that are happening in different places, including the program in Mozambique, which Jordi and his colleague will speak about a little bit later today. In terms of some analytical work at the country level, we are carrying out a series of country studies to examine ways to strengthen and scale up a quality workforce by focusing on a particular service or role within ECD. These studies look at a number of different factors and looking at workers' qualifications and skills, training and preparation, supervision and support mechanisms, and working conditions, and then provide actionable policy and program recommendations. The first of these studies was in Peru, looking at the CUNA visiting workforce and the program there, which Gabriela will talk about in just a minute. And then we also have 2 other studies underway. One is in Ukraine, looking at preschool teachers and assistants, and another is in South Africa, looking at community health workers who are incorporating parenting and stimulation into their health visits. So with that, I will turn it back over to Margaret.
Thanks, Kimby. So just to tell our listeners that over the past year, Kimby has been working very closely with Gabriela, conducting a study about the successes and challenges of the workforce involved in the CUNA Peru. Gabriela is joining us today from Lima. Gabriela, over to you. And just to remind you that many of our listeners are not English speakers, so please speak slowly. So Gabriela, over to you. Gabriela, you need to unmute yourself so we can hear you.
Yes, hello there, and thanks, Margaret, for the invitation to participate in this webinar. Don't worry, I will speak slowly because I'm not a native speaker myself. Today, I will present the results of the study on opportunities and challenges facing CUNA mass home visitors in Peru, which is a collaborative effort by R4D in Washington, D.C. and GRADE in Lima, Peru. I'm presenting today, but as you already know, my colleague Kimby is also here, and she will join me during the Q&A later today. Before going into the description of CUNA mass and the results of the study, I want to share with you the motivation for this study and give you a quick overview of it. So why focusing in the home visiting service of CUNA mass in Peru? First, because the program enjoys relatively high coverage. Nearly 85,000 families participated in this home visiting program in 2016, and there are plans to scale substantially over the next years. Additionally, the program had a recent experimental evaluation that found promising effects on children's cognitive and language development. Yet, the program had faced difficulties recruiting and retaining qualified members of the CUNA mass home visiting workforce, which presents a threat to sustaining program quality and expanding it to reach all vulnerable families in Peru. Given this context, the study's primary aim was to examine sustainability and scale-up of the CUNA mass home visiting workforce service, with a focus on challenges and opportunities experienced by community actors and regional staff, who are central to the delivering of the program. So these two research questions guided our study. First, what are the perceived successes of the program according to these workers I just mentioned, and then what are the challenges to implementations, particularly regarding workforce development. In relation to the methods, the study used a mix of qualitative and quantitative methods to address these two research questions. We first conducted a comprehensive review of existing program documents, which was then followed by in-depth interviews and focus group discussions with a cross-section of home visiting actors in two different regions of Peru, one in the highlands and one in the Amazon region. The study also involves an examination of the current cost of delivering the home visiting service and the estimation of the cost of scale-up. So now let me tell you a bit more about the program. CUNA mass is a large-scale ECD program established in 2012 by the Ministry of Social Development on the basis of the former Wawawasi daycare program. CUNA mass aims to support the holistic development of children under 3 living in poverty, improve families' child-rearing knowledge and practices, and strengthen the attachments between caregivers and children. The program differentiates its services by geographical context, as you can see in this slide. On the one hand, there is the daycare service in marginalized urban areas that provides comprehensive care to children aged 6 to 36 months. The coverage of this service by the end of 2016 was nearly 65,000 children, as you can see. On the other hand, there is the home visiting service in rural communities that delivers individual weekly visits and monthly group sessions for children under 3 and their primary caregivers, as well as pregnant women. The coverage of the home visiting service in 2016 was nearly 85,000 families, which is approximately the 32% of the target rural population. For this particular study, we are only focusing on the home visiting service, and I will now tell you a bit more about it. The home visiting service is implemented only in rural districts with high incidence of poverty and stunting, primarily in Andean and Amazonian communities of Peru. Home visiting activities include 1-hour weekly visits to families, as well as group sessions every 1 to 3 months. A typical visit follows a sequence of 5 activities. First, welcome and greetings. Second, conversation with the family, mainly promoting adequate health and feeding practices. In third place, play sessions divided into free play and structured play between caregiver and child. The fourth moment is a storytelling or singing a song. And fifth, there is feedback from the facilitator to the caregiver and the establishment of a goal for the next week before saying goodbye to the family. CUNA provides facilitators with kits that contain materials to use with caregivers and children during the visits. These kits include activity card, storybooks, doll, and other educational and play materials. Regarding the organization of the program, as you can see in this slide, CUNA operates at 3 levels: centrally, regionally, and locally. The program central headquarters are housed within the Ministry of Development, where a technical specialized team establishes the program guidelines and protocols and provides technical assistance to the regions. Regional offices then oversee the service activities within their jurisdictions, including training and supervising technical teams and community actors, and monitoring program operations. Locally, CUNA operates under a voluntary co-management model between the government and the communities through the management committees, where the latter are empowered to participate in program decision-making and general operations. Given this organization, the program operates a cascade model of training and support, where specialists from central program headquarters in Lima train and monitor professionals at the regional level, who then support the community actors. Facilitators then work directly with children and caregivers. The CUNA workforce, as understood by this study, includes the volunteers at the community levels, facilitators and members of the management committees in this figure, as well as the professionals employed by regional office to train and support community actors. These are trainers and field supervisors in this slide. While our study discusses the situation of all of these different actors within CUNA workforce, I will talk today only about the facilitators who are community home visitors. So let me tell you a bit more about them. Here is a picture of a facilitator conducting a home visit. You can recognize her because she's wearing a pink polo with the logo of CUNA. Families participating in the program are expected to have a space within their house exclusively devoted to the child, as you can see in this picture, and that's the space where the visit takes place. Regarding the profile of facilitators, they are volunteers nominated by their communities. They are often women with at least complete primary education. In relation to their task, they have to conduct 1-hour visits to individual families each week and assist a regional staff member in monthly group sessions. Each facilitator works with approximately 10 families and is supported by a field supervisor who accompanies her during her visits at least twice a month and meet with her in a planning group session with other facilitators every 2 weeks. For this voluntary work, facilitators receive a monthly stipend of about $116. Moving into the findings, for this particular study, we analyzed the following workforce themes: motivation and satisfaction, workload and resources, training and support, and opportunities for career advancement. As I said before, today I will only address these themes from the perspective of the facilitators. Regarding motivation and satisfaction, we found that facilitators expressed feelings of commitment and passion for the program. They enjoyed their work because they could visibly see changes among children and families. When asked about the specific changes they had seen, facilitators often referred to reduced anemia rates, increased coverage of birth registration for children, and children being more outgoing and less scared. More than one facilitator lamented that the program had not existed when their own children were young, as they noticed the substantial progress made by children participating in the program. They also feel appreciated by the children and their families, as the quote in this slide shows. In relation to workload and resources, we found that in practice, facilitators work twice the number of hours set by the programs. In theory, they are supposed to work 10 hours, but in practice, they work nearly 20 hours per week, despite their voluntary status and limited compensation. In addition to conducting hour-long visits for each of her 10 families, a facilitator spent time on other activities, such as travel to families, participation in bi-monthly planning meetings, meetings to make educational materials, and assisting field supervisors in monthly group sessions with participating families. Regarding resources, facilitators' interview highlighted incomplete kits or deteriorating educational materials as one of the most significant challenges they face in their daily work. Inadequate materials present a challenge for the motivation and confidence of facilitators, as these materials create structure for each visit. Moreover, facilitators expressed that the conditions of these materials had a direct effect on their workload, since they spend additional hours each month making materials to replace the old ones or create something missing from their kit of materials. In some cases, facilitators even use a portion of their stipend to purchase supplies for these materials, as can be seen in the quote in this slide. Regarding training and support, in addition to training sessions, the CUNA model of training is centered around continuous support and supervision. This is a key characteristic of this program. The training of a facilitator includes an initial training of 2 or 3 days of duration, 2 in-service trainings per year, 2 group planning meetings per month with her field supervisor, and being accompanied by field supervisor on at least 2 visits per month. We found that facilitators considered training sessions useful and clearly expressed the value of receiving constant support and training from field supervisors during the last 2 activities I just mentioned, which allow them to keep improving in their work. As the quote from one facilitator included in this slide shows, she sees her work as an art that she's constantly refining. Despite the strong positive views about the training model, we also found that facilitators express the need for more training on how to onboard new families into the program. They often expect cash or material goods, such as those provided by other social programs being implemented in the area, and do not sufficiently understand the benefits offered by CUNA. Finally, in relation to career advancement, no facilitator in either region studied had advanced within the program, and developing career pathways for them is not a current priority of CUNA+. So, to conclude this presentation, I would like to share with you some lessons from the CUNA+ home visiting service. First, educational materials are critical for empowering community actors, such as facilitators, who may not have the training or experience to otherwise provide guidance to young children and families. These materials provide structure and support and can be powerful tools for a volunteer workforce. Second, the pay should reflect actual workload and be competitive with alternate employment options. For instance, in the case of CUNA+, the program should increase facilitators' stipends to match their peers who volunteer in non-formal preschools for children between 3 and 5 years. Third, supervision in the field is critical for this workforce, especially in rural contexts where many actors have limited training or experience and work independently much of the time because they are working in remote areas. And finally, career ladders can reward workers for their dedication, retain high performers, and encourage them to see working in ECD as a viable career path rather than a temporary employment. In this regard, the recommendation would be for CUNA+ to offer scholarships to outstanding facilitators each year to study an ECD-related field. Thank you all for your time. The complete report of this study will hopefully be ready in early July on the web, fingers crossed, on the website of the Early Childhood Workforce Initiative. I also leave you here some links to videos on the CUNA+ home visiting service. Thanks again, and over to you, Margaret.
Thanks a million, Gabriela, and a wonderfully clear presentation. You speak perfectly, slowly and clearly. Wonderful. I really applaud the recommendations. Of course, we're struck by the amount of work that's expected of these facilitators, and you know, a relatively low stipend, and also the possibilities for career advancement. So I'm very happy to see that this is one of the recommendations. Our listeners are interested in how the CUNA+ program, how it collaborates with the health service. Can you tell us a little bit more about that? How does CUNA+ collaborate with health services in Peru for effective early childhood development?
Hi, this is Kimby. I think I can just jump in here to answer this question. So there's a few ways that CUNA+ either coordinates with local health actors or uses existing health information. So one way is that during home visits with individual families, the program, it promotes a number of different practices, including hand washing, oral hygiene, consumption of micronutrients, receiving prenatal care, having children attend routine growth and development checkups. And then within the communities where the program works, it coordinates and signs agreements with local health officials. The field supervisors, which Gabrielle talked about, who supervise the facilitators, are in regular communication and coordination with local health facilities. And the program works with these health facilities to collect certain data about the families, which they use to track indicators, such as how many families have health insurance, are pregnant women attending their prenatal care checkups, are children attending their health checkups, are they receiving their immunizations, tracking their anemia levels. And then within the regions, within these 20 different regions where CUNA+ operates, there are also specialists whose roles are specifically focused on health and nutrition. These specialists work across daycare and home visiting, but it's their role to really make sure that both the curricula incorporates health practices and that the program is coordinating well with the local and health and nutrition officials.
Thanks, Kimby. And your impression is that this collaboration and cooperation is working well?
I think that was our impression from some of the conversations we had at the community level. I'm sure there's a lot more to find out there.
Okay, thanks a lot. I just want to remind our listeners that if any of you would like to pose a question to Gabriela or Kimby, if you go to the bottom right-hand side of the tools, the screen, you can type in your question there and we'll try and pick up on those questions during the webinar. I just had one other question, and I'm not sure whether this is for Gabriela or Kimby. Have you been doing anything different to reach the most disadvantaged or the remote families, different to the usual? Our listeners are interested, how do we make sure that the most disadvantaged and marginalized families are reached by programs such as CUNA? So is there something particular that you're doing to reach those most marginalized, more remote, or families really living in difficult circumstances?
Well, I don't know. I wouldn't say they are doing something particularly different to reach them. What I think the programs put the emphasis on actually reaching them with the most pertinent service. So in terms of reaching them, I think they are targeting the program in the same way as they are targeting other social programs. But the program's main concern is providing to those families, children and families, specifically the service they needed. This is why the program has different services according to the areas. And in the case of rural areas, which are very remote and it's very difficult to go there, they don't offer the daycare service, of course, but this home visiting service. And also they make sure through this service that families are actually accessing other important public services such as health, as Kimby already explained. So I wouldn't say there's something particularly relevant on how they target, by the emphasis of the program is on targeting with the best strategy for them. Kimby, I don't know if you would like to add something.
Yeah, I think I would just add that we didn't go into a lot of detail on how the program targets communities, but I think the very kind of foundation of the way that it works is that it is trying to reach the most vulnerable and the most remote families. So the program, first looks within regions at communities and districts where there are high poverty levels, high stunting rates, and where families or communities are accessing other social programs that target these indicators, like conditional cash transfer programs. And then once the program establishes relationships with these communities, the communities themselves help to identify the families that they feel would benefit the most from these services. So I think it's your question, Margaret, is really kind of key to how CUNA operates overall, and is really trying to target what they see as the kind of communities most in need, and then the communities themselves help to determine which families can most benefit from the service.
Thanks a lot, Kimby. Clear. I just have one more question before I move on to Jordi and Nami. This is a question coming in from Ana Maria Rodriguez, and she wants to know if the staff of CUNA or the program, do they have a strong focus on language and cognitive development? And if so, how do you reconcile this with the notion of care? Is this a question, Gabriela, you would like to answer?
Yeah, I'm here. So yeah, the CUNA curriculum has indeed the program tries to promote the holistic development. Among them, of course, children's language and communication. So yes, there is a focus on language, and this is actually why the program looks for facilitators who have actually very good verbal and non-verbal skills. However, during our interviews, we collected evidence on the fact that developing this particular area where the program has a focus, it's particularly difficult for facilitators and the families. I told you about the 5 steps of a typical visit, and if you remember, one of those steps is storytelling or songs. And this activity is mainly related to developing children's language and communication. Nevertheless, facilitators have, according to the program specialist, a lot of trouble actually telling the stories to the children and the caregivers. The narrative is a bit difficult for them, so the program is very conscious that is one of the aspects where they have to go more in depth during the training sessions. So yeah, it is a focus of the implementation, but at the same time, yes, they are aware that it's a tricky area where more work is still needed.
Okay, thanks a lot. Thanks. Kimby, do you want to add something to that?
Yeah, I would just add one quick thing. I think, yes, cognitive and language development is a really kind of central focus, but also, while Gabrielle highlighted kind of some room for improvement in the quality of some of these visits, but there still was an experimental impact evaluation conducted by the Inter-American Development Bank, and they did find pretty substantial positive effects on children's cognitive and language development. So there is a good sign that the program is helping to strengthen those areas, even though there are still ways that it can be done better.
Thanks, Kimmy. We have lots of questions coming in from our listeners now, so if you don't mind, I'm going to stay with you just for 2 further questions. The issue of the storytelling and language abilities of the facilitators obviously brings up the issue of actually what kind of training do the volunteers receive. This is one question. And the other question is, what about father or men's involvement in the whole program? Could you take a minute to tackle both of those issues?
Well, fathers are, of course, involved in the program. When a facilitator gets to the home for the visit, she is actually expecting to work with the 2 parents. In most cases, that is how it works. Of course, there are occasions where only the mother is there, as the pictures you've seen in these presentations. But whenever it's possible, of course, parents are also welcome to these sessions, and also to the group sessions. Yet again, it's not always possible, but that's the intention. Kimby, I'll hand over to you for the next part.
Yeah, sure. I'll just add that fathers are involved, though we did, in some conversations with facilitators, they did say that is actually one area when we asked them what other training or information would you like, one of the areas they highlighted is how to better involve fathers. I think in some cases they were there, but maybe they weren't as engaged as the mothers, or they didn't feel as comfortable working with the fathers. So I think that was an area that was brought up. In terms of what facilitators are trained on, so there is there's a standard set of materials that the program provides different facilitators. I think in general they're taught about how the program works. They're given some basic information on child development, on these kind of different areas, on their children's physical and language and cognitive and socio-emotional development, and what are kind of indicators of their growth. They're taught about what are the roles of other people in the program who can support them. So what are field supervisors supposed to be doing for them? What support can they receive from other program staff? And then a lot of their training is really focused on these materials and activity cards that Gabriela mentioned. So the kind of curriculum and the way these home visits are conducted are really very structured. So there are activity cards and sessions organized by children's age and their development, and the facilitators are trained on how to use these different activity cards depending on the level of development of each child, which materials to incorporate at what point, 5 moments of the session that Gabriela talked about, and then kind of there are supplementary things that they're taught about, like how to develop some play materials and what they can do during these monthly sessions with the families. But I think the bulk is really around these activity cards and how they do these 5 moments of the home visit throughout the kind of 3 years that a child might work with the program.
Okay, thanks, Kimby. Clearly the program is very structured, and this actually probably supports the facilitators who have a pretty low level of education. So the very structured activity cards, I can see how they'd be very important, and also the materials that go with that. Thanks to both of you. Please just stay with the webinar. We'll be coming back to you at the end for a few more general questions, so you can both put yourselves on mute now. I'm going to now hand over to Jordi and Nami. Jordi is joining us from Maputo. Nami is in Seattle on the west coast of the US. And in their presentation, they will be looking in more detail at the interface between health and early learning and development from the perspective of health workers. So I'd like to invite Jordi Fernandez and Nami Kawakio to tell us about the change that has been introduced to the way community health workers support young families in Mozambique. Jordi, over to you.
Right, thanks, thanks Margaret, and hi everybody. I think I'm getting a cold, so my voice is not that good today, but I will do my best. So let me please start explaining briefly who we are. PATH is an international organization with headquarters in Seattle in the States that drives transformative innovation to save lives and improve health, especially among women and children. PATH works across 5 platforms: vaccines, drugs, diagnosis, devices, and systems and service innovations. So PATH was founded in 1977 and currently works in more than 70 countries in the world. In Mozambique, we are active since 2013, and we are running here a maternal child health and nutrition program with a special focus on early childhood development and improving health and development of young children. I will share with you the PATH intervention on integration of ECD on community health workers' work in Mozambique. This is, as you can see, an intervention funded by USAID PEPFAR, the Conrad and Hilton Foundation, and BHP Billiton, which are our donors on this program. So I'm sure that most of you are already familiar with the 1,000 days concept. We are talking about the period that goes from conception to pregnancy up to the second birthday of children. Scientific evidence demonstrates that this 1,000 days period represents a critical period for shaping long-term development outcomes of children. Human brain development is especially intensive during this period of life, and psychomotor, language, socio-emotional, and cognitive functions are developed on these early years. As such, development delays on this critical period of age that may due to health conditions, to nutritional problems, stunting, poor stimulation. So these development delays are often irreversible on subsequent years. As an indicator, in Mozambique, under 5 chronic malnutrition rate is estimated on around 43% of population. ECD is then a multisectoral concept that extends across the whole infancy, However, when talking about these early years, health sector is the only one that systematically tackles pregnant women and young children through antenatal care consultations, postnatal care consultations, child consultations on the first 2 to 3 years of age. So altogether, we have up 26 touch points between caregivers and children up to 2 years old. This is what we call a window of opportunity to monitor child development and counseling of caregivers on best health, nutrition, and stimulation practices for the children. So this is, I'm trying to explain you the rationale of the intervention on this specific range of age. It's important to mention here that the ECD series that the prestigious journal Lancet launched in October last year, suggesting a nurturing care model focused on integrated health, nutrition, responsive caregiving, security, and early learning components, and suggesting health services as an entry point on these early years. So on this regard, PATH is working in Mozambique on integration of ECD into both health services at clinical level and health services at community level. We will love to share with you our experience and lessons on the clinical side. And today we are going to talk of the work we are doing with community health workers, or APEs, Agentes Polivalentes Elementares, on its Portuguese acronym. So who are these community health workers, these APEs? First of all, APEs are community members. They are recruited by health system in a collaborative process involving communities who select and propose a list of candidates that afterwards are tested and recruited by the Ministry of Health. They are not public servants, but have a contract with Ministry of Health. They have basic primary school education. They have to know how to write and read. And then they receive a specific 4 months health training provided by Ministry of Health. APES program is designed to cover rural areas, especially the ones with difficult access to health system due to distance or access difficulties. Estimatively, around 40% of the population in Mozambique have not or has very limited access to health facilities and services. So APEs are a link between communities and health facilities, and serving around 500 to 2,000 persons each. And their package of services include, or is supposed to include 80% of their time on preventative activities such as health, hygiene promotion, and campaigns that they implement through home-based visits, community meetings, etc. And the remaining 20% is supposed to be used on curative activities with a special focus on treatment of child diseases, referrals to health facilities, contraception, and search of patients, HIV patients who fail to continue treatment at health facilities. All APES work is done in coordination with a health unit of reference, where which provides commodities such as monthly medical kits, and also who is supposed to provide supervision to APES work. And as a retention mechanism, APEs receive a modest subsidy that at current exchange rate is around 23 USD per month. This is paid by the government with funding of external donors. So PATH approach to support integration of ECD into APES program is based on a package called Care for Child Development, produced by UNICEF and WHO, and that PATH developed and adapted to Mozambique context for integration of essential ECD activities into health system, both at clinical and community levels. We have developed this package working in coordination and partnership with Ministry of Health at provincial level, and after an initial assessment to better understand existing needs and opportunities. And we have been working with APEs in the country since 2013, so 4 years now. The minimum package we're supporting for ECD integration into home-based visits includes a screening of young children for developmental delays, counseling caregivers on age-appropriate care, nutrition, and stimulation for their young children, and referral to health facilities, to health system in case of developmental delays identified. Working always through health structure, PATH provides technical and financial support to APES training, specific ECD trainings and refresher trainings in other components of APES services, of services provided by APES. We also support meetings with community leaders. We have been also developing IEC materials for APES use, such as counseling cards, posters, homemade toys, etc. And we also support mentoring and supervision activities. So up to now, path intervention with APES happened on Maputo province, which is one of the 11 provinces of the country. But one of the objectives of the project, which is ambitious, as it has to be, is creating an enabling environment for ECD integration into national programs, plans, and materials. We have indeed achieved some results in this area through an active advocacy policy at Ministry of Health level, and some aspects of like integration of ECD into APES training manuals or approval of some IEC materials. However, going to scale at national level has still a number of challenges that are inherent to the APES program as a whole. One of them is that being APES or community health workers a national program, it depends on Ministry of Health national policies and decisions. So changing or influencing these policies, these plans, etc., it's a slow process that takes time. Another aspect is that the limited APES educational background and training, which is very basic and which affects overall quality of the program. Also, the capacity of APES to provide new services. As APES serve population with difficult access to health services, there is a temptation to overcharge them with more and more additional tasks and responsibilities, which is just not possible given their limited capacity as well. So there is need to prioritize which services APES provide. And the natural, in this case, the natural linking between ECD and focusing on child health makes easier the integration of ECD into the package of services. Another challenge is the poor APES supervision and coaching due to the weaknesses of the system. And lastly, the poor compensation, support and equipment that APES receive from the system, which results on lack of motivation, and lastly on resignation of some APES, unfortunately. So what can we do then to enhance APES retention and job satisfaction? On our experience, we suggest a triple approach. One is subsidies. I'm happy to see that some of these conclusions are already shared on the presentation that Gabriela did a few minutes ago. So APES are members of poor communities and they experience similar poverty than other community members. They have families they have to feed and they have the similar needs that the community peers. So if we intend that an APE, a community health worker, dedicates significant time of his day to work with us, and if we expect she or he to do so with quality, some economical compensation is needed for this person to do these activities. However, this is not only about money. I think a very important component is for APES to feel the support from the health system, which means, or which includes provision of training, coaching, supervision, also the provision of basic equipment to do their work, provision of regular supplies. So these aspects also contribute very importantly towards motivation and retention. Lastly, enhancing and promoting community and social recognition of the role of the APES within their respective communities is another key aspect that greatly contributes to APES motivation and retention, and that the system, the sector health, can promote. So this is my description of what are we doing, and what are APES, what is this program, what are we doing, which is our intervention to integrate ECD. I will now hand over to my colleague Nami, who will provide you some details of a study we did related to some of these topics we are talking today. Thank you very much for your attention.
Thanks, Jordi. So, as Jordi said, PATH supported the Ministry of Health Community Health Workers Program in Mozambique to integrate early childhood development in their work. And the Ministry of Health, in considering scaling this up, was concerned about whether ECD integration would A, increase community health worker workload and thus relatedly decrease their job satisfaction. They were also concerned about how ECD integration would affect community health worker productivity and how it would affect their quality of work. And finally, they were interested in understanding what the added value would be of ECD integration. And so we conducted an evaluation last year to look at these 4 areas. Our data sources included program data on community health worker outputs, where we compared data from the intervention district to a comparison district. We also observed community health workers conduct household visits, both in the intervention and comparison districts. And then we conducted in-person surveys with community health workers and caregivers, and also held interviews with community health workers. And what we found was that almost all community health workers working in the PATH-supported districts were very satisfied or satisfied with both their jobs in general and their workload. One community health worker explained, ECD integration made the job more enjoyable. And part of the reason why ECD integration made the job more enjoyable for some of the community health workers was because they enjoyed how integrated ECD work meant playing with kids and connecting with caregivers about playing with kids. It inserted some fun to the household visit rather than just talking about illnesses. We also found that community health workers who were integrating ECD were more productive than community health workers in a comparison district who are not integrating ECD. On average, community health workers who were integrating ECD conducted more household visits, more consultations, and more community talks. Though this evaluation did not explore the reason for this greater productivity, the PATH team's observation is that this increased productivity is likely not due to the integration of ECD, but due to PATH support of community health workers in general that generated motivation among community health workers to perform well. However, it is an important finding that ECD integration does not appear to decrease productivity. We also compared the quality of work by observing household visits. Again, we found that the quality of household visits were much higher among the community health workers who were integrating ECD than community health workers who were not. In fact, on average, we found a 123% statistically significant difference in score between the intervention and comparison community health workers. The biggest differences in competencies we saw were in communication skills, such as praising the caregiver, and covering topics related to development and stimulation, such as assessing the development of the child and asking the caregiver about their caregiver practices. One community health worker said, "PATH support has improved the way I communicate with families. It is no longer just telling communities what they should do, but also showing them how to do it." We also identified many benefits to integrated ECD. Some main themes included an improvement in the relationship between community health workers and families, as well as between families and their children. Community health workers and caregivers reported a change in caregiver practices, especially in regards to change in disciplinary habits and feeding practices. Community health workers and caregivers also noted that they observed a change in children's dispositions to be freer and happier. One community health worker stated, "I see that it has improved my relationship with families because they see that what I do is important. Families now welcome me with joy. Families are grateful to see the benefits." In summary, the evaluation found that integrating ECD into community health worker work did not appear to increase workload or decrease job satisfaction, with some community health workers stating that ECD integration improved their work experience. nor did the integration decrease productivity. In fact, there was a higher level of productivity, likely due to the extra support of training, mentoring, and materials. We also observed a higher quality of community health workers' work, especially in regards to their communication skills. And there are many additional findings of the value that ECD integration brought among community health workers, caregivers, and children. Thank you, and I will now pass it back to Margaret to moderate any questions.
Fine. Thanks a million, Nami and Jordi. Really interesting finding. I'm very struck by the fact, on the one hand, with the added involvement of the early childhood education skills and inputs, the job becomes more interesting, also explained by maybe the extra training. So the health workers were enjoying the work more, getting more satisfaction. And then on the other hand, and this also applies in Peru, they are being paid so little. So they are doing really, really important work and the payment is very low. So I'm wondering about the staff, the turnover of the health workers in Mozambique. Are you managing to retain the health workers or are they leaving? Is this maybe something for Jordi?
Yeah, thank you for the question, Margaret. Well, the reality is that some are staying, some are leaving. As I mentioned in my presentation, the stipend is around 23 US per month, which is really very low. Africa is an expensive place. Nearly everything is imported, so costs are higher than in other areas of the world. So this is something that barely compensates the work they are doing. And as a result, some of them, they are leaving. To put you an example, in Boane, the district where we have been working, we started with 19 APs in 2013. 3 years later, there were just 13, so there was a significant drop of around 30% of trained APs. And this, as I tried to say before, I think that, these three components for retention are important. To some economical compensation, some support, the APs to have to feel support from the sector, and the fields of having commodities and equipment, coaching, training. This is very helpful, and also on enhancing her role within their own communities. But even like this, sometimes these persons find other job opportunities and they just leave.
Thanks, Jordi. And can I just suggest at this point that Gabriela and Kimby, also you turn on your mic, because we'd like really a general discussion involving all of the panelists at this point. And just a reminder to our listeners, if they have specific questions that they want to address to Jordi or to Nami about the study, please use the question box at the bottom right-hand side for that. Jordi, just to follow up on this issue of financial stability of the workforce and high turnover, are you, and this is a question that's come from Sean Williams in Jamaica, who is, like we all are, concerned about the financial stability and, the pay, the very low pay, and the bad working conditions that, and I have to say it's mostly women, are being paid to do this very important work. Are you aware of any plans in Mozambique to increase the monthly payment for the health workers who are doing these home visits?
Yeah, this is not going to happen that soon in Mozambique, definitively. APEs are part of is a national program of the Ministry of Health and are included on the Ministry of Health strategic plan. But the funding of the program is entirely supported by Ministry of Health partners. I'm talking here about training, initial training, subsidies, commodities as medical kits, and as equipment. They receive a bicycle, supervision. So this is entirely funded by some Ministry of Health partners. especially UNICEF, World Bank are very significant. So funding partners, they would like to withdraw the cost of the program, and they would like to see that APES program costs are included on government of Mozambique budget, which has not happened yet, and this is an ongoing discussion for many years. So this should be the first priority, not to enter into details, but Mozambique is also going through a quite severe financial and economical crisis now. So I don't anticipate room for a stipend increase soon. I think first priority should be that the Ministry of Health starts to fund or to co-fund the APES program in its current costs.
Okay, thanks, Jordi. And I'll just stick with you for a moment. A question from Jill McFarren Alvalis, and she wants to know, are the policymakers in Mozambique aware of the success of the program? And linked to that, has there been a cost-benefit analysis done?
Yes, well, we have just completed very recently the study that NAMI has introduced to you. So this will be one important piece on the process of generating evidence. As I mentioned, we are working by the time being in one province. We have 11 provinces in the country, which can be quite different in terms cultural, religious, ethnic, linguistic, etc. So government wants to make sure before they take the decision of making a policy as national that this is well thought and can be adjusted and implemented in the whole country geography. We are working with the Ministry of Health, so yes, they are aware of what we are doing. We have indeed a presentation happening next Monday with Ministry of Health invited, Provincial Health Directorate, the districts we have been working, so in some partners. So we are in the process of dissemination of this evidence we are creating. We have been discussing with the ministry. The ministry is receptive to include interventions on the APES package of services that are not substantially different of what they are doing. So as I mentioned in my presentation, if we are talking about, for example, treating tuberculosis, this will not be accepted at this stage by the ministry. But if we are talking about integrating ECD into the services they are already provided in relation to child health and development, there is room for that. And in our conversations, they have shown openness to that. So I hope that this study will also be an important argument, or will bring some evidence towards this process of creating an enabling environment at national level.
Yeah, I mean that sounds positive, and I guess that there will be also discussions about the possibilities of career advancement and additional training for the staff who will be integrating both health and early childhood education in the home visiting. So good luck with the meeting next week. I would like to ask you the same question that I asked to Peru. Have you been doing something specific to reach the most disadvantaged families in the areas that you've been working in so far?
Right, thanks for this question. Well, as you can see, one of the funders of this intervention is USAID PEPFAR. If you are familiar with PEPFAR, is this presidential initiative that is tackling HIV-affected people. So our main priority, I mean, APES as such, the national program as such, do not make any substantial difference between more or less vulnerable. But at least on our intervention, our target group are OVCs, orphan and vulnerable children. So definitively, yes, this is one of the aspects we have been working with APES to give a special priority to these more vulnerable families affected by HIV in many cases, orphans, etc.
Okay, thanks, Jordi. And I imagine in many of these families, it's grandmothers who are the primary caregivers. Would that be correct?
Right, you find all kinds of distructured families. Also, we are talking about southern Mozambique, an area with, in many cases, poor the men from poor families go to mining to look for jobs mining in South Africa. So in many cases, even if the family still exists and there is no orphanage, the father can be absent for months and just coming back twice a year, and can we have other families also in South Africa. So it's a complicated social situation, and yes, you find a lot of people or children who unfortunately are orphans of father, mother, or both, and then they are raised by grandmothers or grandfathers or uncles, or sometimes stepmothers or stepfathers. So it's a complicated social situation.
Yeah, that actually reminded me, I also wanted to ask you about the position of fathers and men in babies and young children's lives in Mozambique. I mean, you've just mentioned that many of the fathers are absent because they're working in South Africa in the mines, and they may be absent for other reasons. Is your program particularly targeting fathers to stimulate them to be more involved in their children's lives?
Definitively, yes. We have produced a range of materials for counseling and other materials that are not specifically used only in home-based visits. And in all these materials, there are special messages reinforcing the role of father since pregnancy, I should say, and then on very early years of the children to promote interaction, to promote stimulation, to promote playing, to promote not just ignoring responsibility in terms of health and nutrition, which are areas that are in many cases are the females who run at the family home. So definitively, yes, this is something that we consider in our interventions in materials of this program.
Okay, thanks, Jordi. Please keep your mic on, but I'm just going to switch back to Peru for a few minutes. There's a question coming in from Stanislava Vukovic, and she would like to know, is there a training manual available about the CUNA program? And if so, where can this be accessed? Gabriela or
Yes, I'm here. Hi there, thanks for the questions. Yes, there is a manual that unfortunately it's not a public document. We have seen this manual for our study, but it was shared to us. So yeah, no, I'm afraid it's not public.
And the other question from Stanislava was, how do the home visitors actually assess child's development? Gabriela?
Yes, that's a very interesting question. What I mentioned during my presentation is they're assessed based on their observations, but that's not a formal assess. But the program conducts each year the assessment of all the children participating in the home visiting program. They administer a sort of development checklist for all the children involved in the program, but the facilitators are not the ones administering this sort of test, but the field supervisors and the trainers are the ones doing it. They start going to the field and visit each of the families, and once a year during, it's usually around November by the end of the year, that they do this, and they collect information on children's developing for monitoring purposes. I don't think that the instrument they use is publicly available, but it has been developed by the program, and they've been using it for quite a few years now.
Okay, thanks. That's clear, Gabriela. And then there's one other sort of political question. It's actually on your screen, question number 4. Which lessons have you learned in your experience in Peru can be applied in places where there are no donors or where government and community systems are absent or weak? Would you like just to make any comment on your experience in Peru about government or donor involvement or community involvement? And, you know, because we have listeners from all around the world today, and so they're thinking about their own context. And clearly in Peru you have quite some considerable government support for this program. As I understand, no donor support. Is that correct? Gabriela.
I'm here. Yes. Yes, at the current moment there is no donor support. It is financed by the government. Regarding that fourth question, I think in Peru the lesson is actually the opposite one. One of the main characteristics and a key component of CUNA is that this is a program that it's a co-management between the government and the community. So in every community participating in the home visiting program or the daycare program of CUNA, a management committee is formed. This is a committee elected by all the members in the community, and this committee actually runs the program locally in coordination with the government regional offices. So I think people in CUNA always highlights this as one of the main characters of the program. So I'm thinking in the case of Peru, the lesson is precisely the opposite. The fact that this program worked and have been able to scale up precisely because of this partnership between government and community management.
Can I ask the same question to Jordi in Mozambique? And this is the final question to you, Jordi. What are the lessons learned from the experience in Mozambique around donor involvement, government and community systems if they're absent or weak? What have you learned so far on this issue?
Yeah, there is not an easy response to this question. In Mozambique, we are indeed working on a weak government support environment permanently, I should say. The APES program, or Community Health Workers program, has been in place since independence for more than 40 years now, with many ups and downs. In general, whereas the APES project, the APES program has been receiving some support from NGOs or some implementing partners, it has been working better as soon as the support disappears, because the project terminates, the system just breaks down. This is the reality. So after the years, the main two weaknesses of the program identified by the Ministry of Health historically have been supervision and motivation and retention. So some level of support will always be needed. I should say that it's important, as main lessons learned, it's important to integrate the services always into a sustainable platform, as can be a government-led program instead of a project-led program, that must have clear policies, systems and tools, even if it's not 100% perfect, but it's sustainable. I think there is need as well to engage communities deeply on the follow-up of APES community health workers intervention, not to forget that these persons are members of the community, so the engagement with the community and the follow-up of the community itself is extremely important to ensure that the project continues and they continues to provide services. And a third thing to say is the need to secure retention and motivation on the three approaches that I mentioned before. So no magic solutions, but some approaches that can enhance the running of the intervention, whereas you have weak systems or weak support.
Okay, thanks, Jordi. Your recommendations are clear. I'm afraid time is against us, so I apologize for not having time to answer all of the other questions that have been coming in from our listeners. But I would like to thank you, the panelists, for participating, for your generosity in all the preparation for today's webinar, to Jordi in Maputo, Nami in Seattle, Gabriela in Lima, and Kimby in Washington. I would also like to use this opportunity to let you know that the next webinar in the series takes place on the 16th of October, and the topic will be the possibilities and pitfalls in cross-sectoral work in the early years. Now, obviously, we already touched on this a little bit today, but we will have the opportunity to go into that in more depth in October and drawing on experiences from other parts of the world. Do keep an eye on the Early Childhood Initiative website for more information. You can stay connected by signing up for the newsletter on the home page of the Early Childhood Workforce Initiative website. There you'll learn about future webinars, news from our landscape analysis, the country studies, as well as about new studies, resources and events relating to the early childhood workforce from around the world. If you have any feedback or questions about the webinar, or indeed suggestions for future topics, please send an email to Michaela UNESCO, whose email should appear on your screen now. And finally, a big thank you to you, the listeners, for your participation today. Today's webinar was brought to you with technical support from Shusha Sesti and Emily Henry from ISA, and to Julia Cortelesi in ICDI. And that's all from me. Till the next time, hope you took some useful lessons from today's webinar.